I would like to welcome everybody by saying good evening and welcome. And on behalf of the Mount Sinai teams and our partners, the Musella Foundation, the Glioblastoma Foundation, and the National Brain Tumor Society, thank you for joining us as we recognize this International Glioblastoma Awareness Day 2026. Today is much more than raising awareness. It is about empowering patients, families, caregivers with knowledge, hope, and sharing the remarkable advances that are transforming the care of patients with glioblastoma. I think that the say treating glioblastoma truly takes a village is very appropriate here. Glioblastoma is probably one of the more complex diseases in medicine, and there is really no single physician who has all the answers to the questions that patients might have and or every aspect of their care involved. And this is why at Mount Sinai we put together a multidisciplinary team that includes neurosurgeons, neurologists, radiation oncologists, neuro-oncologists, neuroradiologists, neuropathologists, rehabilitation doctors, nurses, advanced practitioners, and clinical researchers to take care of every single patient with brain tumors. Every week we review patients with brain tumors, including glioblastomas, and we come to a consensus of what is the best treatment for each of them. And the consensus stems from all these subspecialty disciplines so that when you receive what are the recommendations, it's not the recommendations of your doctor, but it's the recommendations of the entire team. So tonight it's really a pleasure to be here, part of this fantastic team. My name is Isabelle Germano. I'm a professor of neurosurgery, neurology, radiation oncology, oncological sciences, and global health. And I will kind of serve as the MC to ask our colleagues here a few questions. And the first question goes to Dr. Sheryl Green, who's professor of radiation oncologist. Good evening, Sheryl. If you don't mind, I'm going to start with you and ask you, what are your thoughts about the fact that brain tumor treatment often involves multiple specialists, and how do you envision neurosurgery, neuro-oncology, and radiation oncology work together, and why do you think that this is important?
Thank you, Dr. Germano, and good evening to everyone. Thanks for joining. So I think I'll just sort of say that one of the most important messages that I would like to convey today is that really no two glioblastomas are exactly alike, and just as importantly, no two patients are exactly alike. So every tumor has unique characteristics, every patient has different goals and priorities, and every treatment plan should be tailored specifically to that individual. So we'll work through and show you how the team of specialists works together to create the most personalized and effective treatment plan. So the patient is always at the center of everything we do. And rather than one physician making decisions alone, experts from the multiple specialties will meet together to review every patient's case in a multidisciplinary tumor board, as Dr. Germano mentioned. So during these discussions, we carefully review many factors, including the location and size of the tumor, the patient's symptoms, their overall health, the molecular and genetic features of the tumor, which have become increasingly important in guiding treatment. Just as importantly, we consider the patient's own goals and preferences. Some patients prioritize maintaining independence, others want the most aggressive treatment possible, and many are balancing work and family responsibilities. So the three physician specialties playing the central role in the care of patients with glioblastoma, firstly is the neurosurgeon, who's usually the first specialist involved in meeting a patient with a glioblastoma and the first step in care. The neurosurgeon's goal is to be able to surgically remove as much of the tumor as can be done safely while protecting critical brain function. The tissue obtained during surgery also allows us to make an accurate diagnosis and perform important molecular testing. The radiation oncologist typically becomes involved after surgery, and we use highly sophisticated imaging and computer planning to precisely deliver radiation to the areas at highest risk while minimizing exposure to the surrounding healthy brain. The neuro-oncologist manages the chemotherapy and many of the newer treatment approaches available today. They also help manage medications, monitor side effects, and adjust treatment over time. Although each physician has a different area of expertise, we don't work in isolation. We communicate regularly, review imaging together, and continually reassess the treatment plan as new information becomes available. Next slide, please. Treatment itself isn't a single event, it's an ongoing process. Most patients begin with surgery whenever it's appropriate and safe. After surgery, the team meets again to review the pathology results, the MRI scans, and the molecular testing. Together, we develop an individualized treatment plan, which often includes radiation combined with chemotherapy. But our work doesn't end there. Patients are followed closely with regular MRI scans and clinical visits. As we learn more about how the tumor is responding, the treatment plan may be adjusted. If new therapies, clinical trials, or additional treatments become appropriate, the team discusses those options together. This continuous collaboration allows us to respond quickly and provide care that evolves with the patient's needs. The best care for glioblastoma doesn't come from one physician, it comes from an entire team working together with one shared goal, which is providing the best possible care for each individual patient. And most importantly, patients and families are never facing this journey alone. They have an entire team standing beside them every step of the way. Thank you, Dr. Germano.
Thank you, Dr. Green. So this really amplifies that wording, that it takes a village to take care of the patient. And you mentioned that neurosurgeons at times are the first one to see the patient at presentation. So I'm going to ask Dr. Raymund Young, who is our Director of Outreach for Neurosurgical Oncology, what are the latest advances in surgery for glioblastoma? And I know that there are quite a few, but maybe you can touch on a couple of them. Ray, you have the floor.
Yes, thank you. I think you can hear me, but sorry, my video may not be working at the moment. You could put up my slide. Great. Yeah. So as Dr. Green mentioned, treatment for GBM often starts with surgery. And one of the main reasons for this is that it's of great importance to be able to remove as much of the tumor as possible and in a safe manner. And a lot of the technologies that have been developed over the last 5 to 10 years have really been focused on helping the neurosurgeons remove glioblastomas as safely as possible and maximizing the extent of that resection. And so just to point out some of these technologies that we're now using on a routine basis, one of them is on the imaging end, in MRI, new forms of MRI, which are being developed. So on the left here, we have a view of a conventional MRI that shows the tumor as well as normal structures of the brain. But on the right here, we have a form of MRI called tractography that now is able to show in much greater detail functional connections within the brain that are extremely important in terms of preserving the patient's functions and abilities after a surgery. And so neurosurgeons are now able to visualize, for example, the pathways in the brain that are responsible for motor movement, as well as language, as well as memory, as well as visual function. And these are all rendered in different colors that you can see here on the right side of the screen. And we're able to develop plans now that allow us to safely separate tumors from very close proximity to these tracks. This information also allows us to plan the surgery in such a way that we're using the correct tools to monitor these tracks while we're working. And so this helps us achieve the end result of a maximal removal of the tumor, but still preserving important functions of the brain. If you go to the next slide, here we have another form of technology that actually helps us actually visualize tumor directly in real time using microscopes and other forms of magnification. On the left-hand side here, we have conventional white light that's been used for many decades in our microscopes to carefully visualize the tumor, which can actually look very similar in, especially towards the edges of the tumor to normal brain substance. But with 5-ALA or Gliolan, which is given as a drink, an oral solution to the patient a couple hours before the surgery, 5-ALA is actually absorbed by the tumor and under blue light will fluoresce red. And so we can switch between white and blue light. And under white light, tumor may not be obvious, but under blue light, we see that there's significant amounts of red tumor that then becomes apparent, and we can continue to remove that as long as we know that we're safely away from those critical connection pathways that I mentioned before. So tools like this, in general, help neurosurgeons, achieve a maximal safe removal of glioblastoma, which many studies have shown is something that will improve outcomes after surgery and into the next phase of treatment, radiation and chemotherapy.
Thank you, Dr. Yong. This is very important, and Dr. Yong actually pioneered some of this implementation of the 5-ALA. So this is really something that a lot of physicians have now in their surgeons have in their armamentarium. Another important thing in trying to achieve the maximal safe resection is really understanding where the tumor is. And this used to be done at the time of surgery. When I trained, a lot of the surgeries were done awake when the patient is woken up during the surgery or never put asleep. And there is some recording that is done. Those surgeries now are very rarely needed because we have so much better preoperative brain mapping. And the one thing I want to share with you today is the navigated transcranial magnetic stimulation. We just acquired this at Mount Sinai. This allows us to non-invasively, with a magnet that is held against the patient's head prior to the surgery, to map the brain and to really understand if that tumor is within or abutting or away from one of the crucial areas of the brain, like the motor cortex or the speech cortex. This equipment is mostly used to look at motor mapping. So we want to be sure that when we resect the tumor, we are not interfering with the area of the brain that is allowing the patients to move. And some of the technology is also for mapping of the language. So we want to really see where the language is, the representation of that cortex is. And we used to do all this in surgery, as I said, with the patient away, with the neuropsychologist there, with the images shown. There are a lot of disadvantages to that. For one thing, the safety of all of this is borderline. Second, there is a lot of fatigue that develop over time, so the patients can make errors and actually can guide us wrongly. And third, which is something that I'm very interested in, patients that speak multiple languages, it's very hard to map all those languages because each of the language usually requires at least 45 minutes. So with this device, we're really happy to be able to do all this for the patients prior to the surgery, and therefore making that experience of surgery much shorter and much safer. I would like to show you just a quick YouTube. The audio is really borderline, but there is a capture underneath, and also I can read it. It's about a minute. So I think that this is an interesting story that some of you might enjoy. Here we go. I started thinking that I'm having a stroke. I never experienced anything like that. Something horrible was about to happen. Numbness in my left shoulder, in the upper left arm. I noticed that my left leg was numb, which I never experienced before. I called EMS and I was rushed to the ER. I want to get a second opinion, and I wound up here at Mount Sinai. From the very first moment that she saw the MRI, she said, we need to get this out of here. These tumors are very aggressive, so you have to decide rapidly whether or not you operate. This technology can show the patient and the doctor in real time exactly where that piece of eloquent brain is. Being able to see the brain in the machine, understanding why it was there, was extremely important for me. I said, let's get the show on the road. I had the procedure on Monday, and I was discharged 2 days later. The surgery is much faster because since we have all this information up front, and because the surgery is shorter, the patient recover faster. I'm here. I was able to meet with the doctor. I want to get back to doing what I was doing before. I love to cycle. I love to play tennis. I have a 95-pound dog, so I want to get back to those things when I'm physically capable of doing those. And our patient is actually capable of doing those, and he's taken care of by our radiation oncology and neuro-oncology team. So with that, I'm going to pass the ball to Dr. Lazarev from radiation oncology, and I would like to ask him if you could perhaps share with us what are the latest advances in radiation strategies for glioblastoma.
Thank you. Thank you, Dr. Germano. Thank you, everyone who came to this webinar. And I think we have some slides, right, Dr. Germano?
Yes, we do. And let's see. We are just trying to figure out where did the slide go, but the slides are still here. They did not go away. And here we go.
Great. So I'd like to start with some perspective. Radiation has been a cornerstone of glioblastoma treatment for over 50 years. So radiation is not new, but what is new is, and what I wanted to highlight today is how dramatically the way we deliver radiation has changed, especially over the past decade. Let's go back to the 1970s. You can see here the drawing of a circle. Let's presume that this circle is the brain. So back in 1970s, 1980s, radiation for glioblastoma was actually delivered to the entire brain, and we still call it whole brain radiation. And as you might imagine, treating the whole brain, healthy tissues included, came with real costs, particularly for memory, concentration, day-to-day thinking, hormonal changes because of some of the central gland, pituitary gland, vision, hearing, because of how much normal brain tissue was exposed to full dose of radiation. Fast forward to today, the picture looks completely different. Nowadays, we use a technique called VMAT, volumetric modulated arc therapy, which is a highly conformal, precisely shaped form of radiation, whereby we focus our radiation beams precisely to the surgical cavity. You can see here in the green. And then we add a low margin to account for potential microscopic disease and day-to-day setup variations. And that means that we can actually spare the majority of the healthy brain while still treating the area of concern effectively. And this is generally, I would say, one of the biggest quality of life advances in our patients that I see. Most of our patients tolerate treatment well with several but very mild side effects, some fatigue, some headaches, some mild nausea. But most patients actually are able to continue going about their day, whether some patients continue working, other patients going to school, other patients going for walks. So this form of radiation allows us to be a little bit more pinpoint. Now, again, slide 2. Now, there are patients that for whom going for treatment for 6 weeks can be really challenging because of they're less robust physically, they're more older patients. And now we have well-tested evidence that for some of these patients, shorter radiation schemes, such as 1 week, 25 and 5 treatments per week for frail patients with smaller tumors, 2 weeks over the course of 10 treatments is an option. And the most tested option has been this 3-week option, whereby patients receive standard of treatment radiation with concurrent temozolomide, the chemotherapy that Dr. Friedman will discuss in a little bit. And we have the data to support this approach for patients who are elderly or less robust, that it provides the best possible survival outcomes. Now, here's what's newer. There's some new data coming out of Canada and China, if I'm not mistaken, where we have some phase 2 data showing that patients being treated over 20 treatments compared to 30 treatments standard of care actually may derive the same outcomes in terms of efficacy and safety. And that's generally exciting, but I want to be careful and precise. This is the phase 2. We call it not fully comprehensive data, if you may. It's promising. It hasn't been widely adopted yet, but I think it's a great example of where the field is heading towards focusing more of a quality of life, shorter quality of life sparing and shorter course of radiation. Now, I just wanted to highlight a couple of points about the timing of the radiation. It is important that we do start treatment within 4 to 6 weeks after surgery, but I don't want to be absolutist. We might sometimes permit 1 or 2 extra weeks to allow for wound healing and recovery and some other individual factors. But there is some data suggesting that delay of the treatment beyond the time point may be associated with less favorable outcomes. So it's true. We these days here at Mount Sinai, many other oncological centers across the country try to start radiation within 4 to 6 weeks. And that's when I wanted to mention some of the caveats related to the proton therapy. You might have heard in the news or might have seen some billboards. So if we can move to slide number 4. So proton radiation is a advanced form of the radiation that has very good theoretical promise because of the way radiation is delivered to the area of the concern. Theoretically, protons should cause fewer acute side effects than standard radiation because the beam deposits energy right at the tumor and then it stops rather than continuing through the healthy brain like with standard radiation. But here's my honest and practical experience. For most of the patients who have high-grade gliomas, such as glioblastoma, in practice, the acute side effects, those that happen during radiation, are generally pretty similar to what we see with standard radiation. The theoretical advantage may have to do with the long-term side effects, but this, I wanted to highlight, this is strictly theoretical and on-paper advantage. There was a study that was just published, that was just presented a few months ago, that looked at the dose escalation, meaning a higher dose of radiation delivered with protons to 75 units of radiation over the standard treatment. And it showed some improvement in survival, but I don't want to oversell this outcome because the absolute survival benefit was modest, about 50% versus 43%. So it's difference of roughly 7 percentage points. So in terms of time, the survival advantage was only about 3.5 weeks. So I think this is something that we studied, and I think this is an exciting avenue to see where proton treatment goes. But the important thing is that proton therapies centers are limited, and getting access can mean delay in starting treatment. And for fast-growing tumors like glioblastoma, delay can be very important concern. And the last thing I wanted to highlight is a re-radiation, and retreatment. So unfortunately, these tumors do tend to come back, and when we come back, we ask questions: how do we treat them? Surgery, chemotherapy, clinical trials. when we come to the questions of radiation, we ask the question, has the tumor come back in the area of the original treatment or outside of what we call treatment area? If it's outside of the prior radiation field, depending on the size and the location of the tumor, a lot of times these patients will go for surgery, and then we can offer them a standard 6-week course. Or for some of the smaller tumors in sensitive locations where surgery may not be an option, we can offer them a short course of a high-dose focused radiation known as SRS or SBRT, and no more than 5 treatments. However, when the tumor comes back in field, which unfortunately most of glioblastomas tend to recur, and unfortunately the most robust data on the role of re-radiation did not show survival benefit, showing that for patients who have recurrence in field of a prior radiation, unfortunately, the survival benefit is not there. So the key message, so what's possible depends heavily on where the recurrence is, and we have to be honest about the evidence limit and not just as promise. Thank you, team.
Thank you so much, Dr. Lazarev. And the concept of using radiosurgery for glioblastoma it's not novel. Dr. Green and I, about 15 years ago, published a series of patients. Clearly, radiosurgery is not meant to be a treatment for patients with glioblastoma, but as Dr. Lazarev explained, if the tumor recurrence is outside of the original radiated field, it might actually have some advantages because it's a very short treatment and it's usually very well tolerated. Moving on to something really exciting that patients are always asking us about are what about trials? What are the promising trials for glioblastoma? And with that said, I would like to introduce Dr. Varun Jain, who is a neuro-oncologist at Sinai, and he will share just a few slides with us on trials.
Hi, good morning, good evening, everybody. Sorry, again, I think there's something wrong with the video, so you'll be able to hear me only. Thank you, Dr. Germano, for arranging this webinar, and it's a pleasure to be here. For most of us and patients and families who have known, management of glioblastoma, we all know that for the last 2.5 decades, glioblastoma has been treated with surgery, radiation, and chemotherapy, primarily temozolomide. There have been multiple trials in the past, and we haven't had any significant breakthroughs, and therefore we are still following the guidelines which were set 20 years ago. Over the last few years, the field of oncology, the research and the trials have pivoted more towards enhancing the immune system and letting that fight and attack the cancer cells. Among that, I'm on the group of therapies, CAR T-cell therapy, immune checkpoint inhibitors, tumor vaccines, and oncolytic virus therapies have evolved. And many of us have heard these names and their efficacies and their nice results in the systemic cancers, but not specifically in the primary brain tumors. The CAR T-cell therapy is basically the modification of T cells and reinfusing them to let them fight the cancer cells. Immune checkpoint inhibitors are enhancing the immune system. Tumor vaccines are small molecules, cellular molecules, but they are modified in a way that they are able to recognize the tumor and trigger the immune response. Virus therapies have also evolved and been tried, which involves the weak pathogenic viruses, which eventually find their way to the tumor cells, replicate in them, and eventually cause death. The trial which we have at Mount Sinai right now is called as GBM Agile trial. Dr. Germano, I think you may have to enlarge the screen if possible. Or if not, I'll just continue.
Maybe I'm not sharing the correct one. Sorry about that. Let me just redo this. Okay.
So at Mount Sinai, currently we have the trial known as GBM Agile, and it's a multi-center international phase 2 and 3 trial. I really like this trial. There are 2-3 particular points which make it very patient friendly. First, the GBM Agile trial allows to study multiple investigational drugs at the same time, unlike other trials which have been done in the past. Second, it has a very dynamic patient allocation, which means that if one of the experimental arms is showing good results, patient automatically will be randomized to that arm to get the benefit. Not many trials have that. Second, this type of study, the structure also allows to add or drop more experimental arms without pausing or stopping the trial. The primary endpoint of the trial is, again, looking at the most important thing, that is overall survival. The secondary endpoints are progression-free survival, tumor response, safety, and quality of life. Next slide. Every trial has two arms. One is control arm, another is experimental arm. Control arm of these trials have the patients which are randomized to the control arm are getting treated by the standard of care therapy, which includes, again, surgery, radiation, and chemotherapy. Next slide, please. The experimental arm, currently GBM Agile, there are 4 experimental arms which are studying 4 different drugs. I'll give a little bit introduction of each one. First is troriluzole. It is a glutamate modulator which has a negative impact on the tumor growth. Another drug which is called as riluzole has been studied in a very fatal neurodegenerative disease and has shown very positive results. So we are hoping that with using the troriluzole, we may have some positive results with the GBM patients. It is an oral drug and patients can take them at home. Second arm consists of the investigational drug called as ADPEG-20. It is a metabolic enzyme which is designed to deprive the tumor cells of arginine. Arginine is a very essential amino acid. So if this drug makes arginine unavailable to the tumor cells, they eventually will stop growing and will die. Third arm consists of AZD1390. It inhibits an enzyme called as ATM kinase. ATM kinase is a very important enzyme for the tumor as it helps in DNA repair. Inhibiting this enzyme enhances the tumor death and its inability to repair. Fourth arm consists of a drug, tinostamastine. It is an alkylating agent which inhibits the histone, which is actually a protective covering around the DNA of the tumor. So it unwinds that protective covering and makes the tumor cells more susceptible to stress and eventually leads to death. Many of you must be wondering that, we have the trial for the newly diagnosed patient. What about for those in whom we are seeing the tumor progression in the later stages? So if everything goes well in the next few weeks to months, we are expecting to have a trial called as IPAX-BRIGHT for recurrent glioblastoma at Mount Sinai. It is a trial which evaluates an agent called as TLX-101, which is actually iodine-131, also called as idofalin. This has radioactive properties, but is given intravenously, along with the lomustine, which is the standard of care in the recurrent GBM patients. This drug makes its way from the bloodstream to the brain and eventually to the GBM cells. It accumulates there and with its radioactive properties eventually causes the cell death. We are very excited to have this trial at our Mount Sinai in the next few weeks to months. And will give our recurrent GBM patients a great opportunity. Next slide.
I think this is up. There's one more. Yes.
Yes. My talk will be incomplete without mentioning and telling you about the support system for the research patients at Mount Sinai Hospital in the Neuro-Oncology division. We have a dedicated research team. It has mainly 3 personnel, Disha, Camilla, Suzette, who wear different hats, but basically help you and your family understand the clinical trial and answer all the questions. They serve as the point of contact for all the queries and challenges that patients face during the treatment. They are always there during the patient's visit, and their focus is to make sure that the patients who are enrolled in research, their journey goes very smooth. Under the leadership of Dr. Friedman, who is our division chief, we hope to solidify our research portfolio in the future. And we at Mount Sinai, with our entire team of neurosurgeons and radiation oncologists, will strive hard to provide the best care possible for our glioblastoma patients.
Thank you so much for this very nice overview of so many exciting trials. And our last panelist is Dr. Josh Friedman, Chief of Neuro-Oncology at Sinai. And I would like to ask you, Josh, if you could kind of share with us your thoughts about what advances in brain tumor care are most exciting that are coming up, and how things can change for patients between now and the next few years.
Thanks, Isabel. Thank you for having us here today. I think it was said in the beginning, but we're a very multidisciplinary group to take care of these patients. And so we all work together on a daily basis. And I agree with sort of everything that's been said before. And I think, looking ahead to the next 10 years, you kind of have to look back 10 years to understand where we've come. And Dr. Jain had mentioned all the trials that are coming out, because the standard of care sort of has been the standard of care for almost a quarter century. And so what have we done the last 10 years? And I think the way to think about it is we finally have a better understanding of what we're treating. So 10 years ago, we used to look under the microscope to understand what we're looking at, a glioblastoma. Now, 10 years later, we have a much better understanding of the molecular, which is the engine that drives growth of these tumors. So it's understanding the biology of them. It's sort of the molecular era. And so the last 10 years has been an explosion of knowledge in this type of tumor. And what that allows for is accurate diagnosis, better prognostication, smarter clinical trials, because you need to know what you're enrolling into the right trial, and then more targeted therapies. So if you understand what's driving growth, the mutations in these tumors that are the engine, then you perhaps have a targeted treatment to go for that mutation. So now where we are today is we view glioblastoma not just under the microscope, but as infused with this molecular information, as this biologically defined disease. So now the next 5 to 10 years, why I'm very optimistic and our field is optimistic, is we finally have a better understanding of what we're treating. And it's taken advances in biology, chemistry to understand what, all these factors that I mentioned so that we can better treat. And so I think you're going to see the next 5 to 10 years a continuation of that learning of integrated tumor biology, whether that's genomics, epigenetics, which is how genes are turned on or off without changing the DNA, and even the microenvironment of how these tumor cells interact with the rest of the brain. But more so in terms of the treatment in the next 5 to 10 years, I think you're going to start to see more precision medicine take effect to match therapies to individual tumor biology. So now that we better understand what we're treating, you can better target the treatments to it. A big part of treating patients with brain cancer is, as a neuro-oncologist, is monitoring over time and understanding how the tumor is responding to therapies. And we don't have the greatest measures for that. They're good. We have MRI, which has been the gold standard for a long time. But I think what you're going to see in the next 5 to 10 years is more improvements in imaging techniques and advanced techniques such as perfusion imaging, PET scans, and other modalities that help us better understand how the tumor is being treated over time. And then the other thing with monitoring is you're going to start to see liquid biopsy come into effect. And so traditionally, you need a biopsy to understand from the tissue itself, from a neurosurgery procedure, to understand, to get tissue to send to pathology. But the problem with brain tissue is it requires, a larger neurosurgical procedure compared to other cancers in the body, like lung cancer. And so one of the hot topics in our field has been liquid biopsies. Can you get more non-invasive biopsy at more frequent time points? And so what we're seeing is lots of studies looking at the fluid that surrounds the brain and spine that bathes the central nervous system to see if you can capture these mutations that I mentioned before, the molecular, in a more non-invasive technique. And the evidence is showing that you can. So what you'll see in the future in trials is that longitudinal monitoring will not just be done by tissue, but it will also be done by sampling other things like the spinal fluid or even blood. So treatments, Dr. Jain had mentioned different types of treatments in some of the trials that are ongoing here and coming, but there's certainly a large amount of them if you're looking at sort of the ecosystem of clinical trials, and they range from CAR T cells, vaccines, bispecific antibodies, oncolytic viruses, like Dr. Jain mentioned. And I think what we're going to see, and as we've now learned about these tumors better and how to rationally put them into clinical trials, is the results of those clinical trials over time. And I think my view, my optimistic view, is that what we'll end up seeing in the next 5 to 10 years, it's not going to be one specific breakthrough, one specific trial. What we're probably going to see is the sequencing of different treatments over time to better treat this tumor. And I am very confident and optimistic that that's what we're going to see as a very collaborative field, not just in neuro-oncology with other institutions, but across neurosurgery, radiation oncology, radiology, pathology, and neuro-oncology. So I think overall, looking at the next 5 to 10 years, I'm very enthusiastic and optimistic with all the advances in the knowledge of the tumor, understanding the molecular, that now we're advancing to a point of rationally using these new therapies, and I have a feeling it will be sequencing them in different manners in a precision technique to treat these very difficult tumors.
Thank you. This was an incredible view over the future and very exciting times. There are a few questions that came in through the WhatsApp and through the chat. I selected 3, and the first one is for Dr. Green. The question is, thank you for your beautiful introduction about the importance of a multidisciplinary team. How do I choose between staying home and staying close to home and being taking care of the doctors that are 2 or 3 blocks away, or coming into the city and being taken care of a big team?
So I think, to be fair, it might be worthy of meeting both teams and getting an assessment of what your treatment options are. And I think at that point in time, many patients have sort of a gut feeling about what feels right for them in terms of treatment. I think from a radiation standpoint, I'm interested in the technologies that we have available for really delivering optimal treatment. And, there are some variations in technology and expertise that's available. So I think I would try and take the time to at least explore the options and better understand where you're going to get optimal treatment. That being said, there are practical aspects to life. Some patients have family obligations that make it more difficult or more challenging to travel. I think it's important to understand that we have a whole team of supportive care working with us. We have social workers and transportation coordinators, and oftentimes we're able to come up with ways of supporting and assisting a patient in traveling a little bit of a longer distance in order to come here for treatment. So I think it's just part of having a really broad and overall conversation with your physician and being honest about the needs that you have and seeing what we can do to deliver on those.
Thank you. And Dr. Lazarev, perhaps you want to comment on occasional patients where you collaborate with the local radiation oncologist team to have the treatment delivered.
Local radiation oncologist?
Yep.
Yeah, so the treatment that we deliver, fortunately, is a standard treatment that can be done at a facility closer to patient's home, because sometimes traveling for treatment can be very exhausting. We have some patients occasionally choosing to stay with us for clinical trials, and then requires us to for patients to be treated here. But a lot of times, We exchange, we talk to local radiation oncologists either on the phone or via email to kind of go over our treatment plan. Obviously, it will be up to the local radiation oncologist to finalize the decision about how to treat, but generally, we all work in a collegial environment to ensure that patient gets the treatment that will give them the best possible outcome in terms of both quality of life and survival.
Yeah, and again, this team is not only multidisciplinary, but we really want to work with the physicians in the community. So whatever we can do to facilitate that collaboration and also to look at patients' needs. The second question is for Dr. Jain and Dr. Friedman. Thank you for giving us a view into the future and for reviewing the current trials. How do I know that I'm not a guinea pig? Who wants to take the first?
I'm happy to. I think that's a question we commonly get as neuro-oncologists because our role, I always describe it as there are three sort of buckets of treatment. There's surgery, bucket one, bucket two, there's radiation, bucket three, there's everything else. And that's sort of where the neuro-oncologist lives. And so, chemotherapy, immunotherapy, clinical trials. And so the question that tends to come up is, well, how do I know I'm not just being used for a clinical trial? It's just, a number for a trial. I think, when you go, the best way to say is when you go into our field, not just neurosurgery or, radiation oncology or neuro-oncology, we go into our field to help people. And so and every patient will tend to ask, would you put a family member on this clinical trial? And I tell all my patients, I would offer the same thing to my family members that I would offer to you. My goal is to offer the best treatment, the most aggressive, safe treatment to tackle this tumor, to put you in the best position for a long runway where it doesn't grow back. And so I would not offer a treatment to a patient that I didn't think would benefit them. There's always risks, and there's certainly patients that we've all had who've had side effects from clinical trials. But what I always stress is, if I'm offering the clinical trial, it's not because I'm getting a kickback. It's because I think it's in the best interest of you to treat this tumor.
Thank you, Dr. Friedman. Dr. Jain, any additional words?
Yes, that's always a very important question from patients when we discuss with them. And what we do is we always have full transparency when we are discussing the trial, a detailed discussion which involves what is the investigational drug and what is the scientific reason and how could it help the tumor. So that helps to alleviate the patient's anxiety a little bit. Second, what Dr. Friedman said, it is something that which we would offer to our family and close friends. So when we put it that way, our patients feel that we are doing something for their good and not something that will benefit us. Third, I also tell my patients that at any point of time, if they feel that trial is not going the way as they thought, they have no contract and no foundation to continue the trial without their wish. So they can always come out of the trial if ever they feel things are not going their way. And yes, I personally, I never push patients for trial. I always, update them, give the knowledge. But I always, encourage patients to make their own decision. And in that way, our relationships with our research patient is always, on the positive side.
Thank you so much. And finally, the last question to Dr. Yong. How important is it to get a second opinion?
I always encourage my patients to get second opinions. I think that it's always great to get different perspectives. Different surgeons may have slightly different recommendations in terms of their overall surgical plan, and patients need to find a team that they're very comfortable with, and a surgeon that they're very comfortable with. So I think that getting a second opinion is important. The caveat being that we are also dealing with glioblastoma, which is an aggressive tumor that does require timely treatment, diagnosis, and the initiation of adjuvant treatments like radiation and chemotherapy, and that really can't begin until we have the tumor removed and a firm, diagnosis based on the tissue. So while I think it's important to look around for the team that's right for you, keep in mind that you don't want to delay treatment to the extent that it's doing a disservice to you and your overall treatment goals.
Thank you so much. And with that, I think we reached the hour. I would like to thank each of the team members that participated tonight, all of you that listened to us, and those that were able to stream this, and those people that hopefully will watch this in the future. Thank you.